Let's do the official bit. Hello, my name is Jono Broad. I have the great joy and privilege of supporting this event as its chair for this very first session and the morning section. And I'd like to start off by just highlighting just one of the great organisations that you'll be meeting later on. The team and great colleagues of ours at Great Minds Together very kindly sponsored all of the NHS places at this conference. And so I'd like to thank them for making that finance available to us so that we can indeed get together and really look at the long-term plan and the way that ICS's, integrated care systems, can support the development of the NHS over the next few years. I will also caveat this with, I would say almost, the king is dead, long live the king, i.e. the long-term plan, of course, is going to be under review following Lord Aradaz's review, which, from my understanding, we expect NHS England to publish on Thursday with a ministerial response either on Friday or early the following week. So all of the discussions are caveated with, we're giving you our best view, but we may not know it all, and in fact we probably won't. With that said, thank you very much to GovConnect. Welcome to this conference. Welcome to a day where hopefully you will be able to share with each other, network with each other, learn and understand from each other's experiences everything that we can do together, because nothing that the NHS does is done by single people. It's done by teams and by people networking and bringing their knowledge to the floor. So thank you for attending. I'm now going to change hats, if you don't mind. That bit was the official I'm from NHS England, and I was very proud to be part of this team. But when I worked originally with GovConnect, they always asked me to come and speak in my other guise. So it's always important to acknowledge which hat you're wearing, and I'm about to swap hats. So let's start the next part of that session, if you don't mind. Hello, I'm Jono Broad. I'm a long-term conditions patient. I actually have cystic fibrosis. I'm going to use this one. We changed to this one, if that's right. I always do a bit of a walk around. I can't abide being hidden behind lecterns, because quite often long-term conditions patients are hidden behind lots of things rather than being seen by the NHS. And I wanted to talk to you today about what the long-term plan and what integrated care systems should or could be doing for patients, and much more importantly, what do patients expect? Now this is going to freak out the sound man, because I'm going to come down. And I also wanted to know what you wanted and what you expect from the day. Why are you here? What is it that made you decide that today was going to be valuable for you, and what is it that you want to get out of a meeting of such minds? So, first bit of audience participation. Why are you here? What are you doing? What's your voice for? I'm going to start picking on people if people don't start shouting at me. Go for it, nice and loud.
I'm here to find out any ways in which housing can work with health in tackling long-term conditions or any of them.
First of all, I love you. Housing and health have the most impact working together than if you don't work together. I'll guarantee you that as a long-term conditions patient, the biggest impact in my individual life was when I was able to get into social housing, out of damp, horrible private rented housing, to the extent that before I got into social housing, my average hospitalisation was 16 weeks a year. After I was in social housing, my average hospital going into hospital each year went down to 4 weeks a year. Had nothing to do with the health service. It was purely the fact that I was in a good social home. So yes, I absolutely love you, and I hope we can get you working together with us. There was another one back there. Nice and loud for me.
Diet
Yep.
and yet there is very little investment in improving diet. It's the single largest cause, dietary inequality, the single largest cause of health inequality. It's 25% of the cause of health inequality. And I work in diet, so I want to see how diet can be raised in this discussion.
Brilliant. So, dietary work. How do we get people to have a healthy, good diet? 2 seconds. You say that with the fat bloke at the front. It's absolutely fine. I love it. It's absolutely fine. Do you know what? I've had more than enough dietitians try. But it's fine. It is about working in partnership with patients. So I just want to click on and tell you what I think. And now listen, I always say this. I do not speak for patients. I give you my view as a long-term conditions patient from my point of view. I'm not representing anybody. I'm not telling you what the population says. I'm just telling you what I think, and I think it resonates with other people, and you can decide whether it does or not. So when it comes to the long-term plan and to integrated care systems, I think patients want several things. All right? And I think it starts with this. 8 steps to what I call my perfect patient pathway. If everything could go right, these are what would happen, okay? The first one is, am I getting the right care? Now, just to shock anybody that's got a clinical explanation in the background, I got my cystic fibrosis diagnosis at the age of 35. Okay? Up until that point, I'd been diagnosed by the Brompton, the most specialist respiratory hospital in the country, as having bronchiectasis, but being, excuse me, a big fat bloke or a big fat youngster, it didn't match what they normally saw with CF. So they didn't do the diagnosis of CF. But I got my diagnosis of CF. So I want the right care. But to get the right care, of course, you want the right diagnosis. Quick note, September the 16th, World Patient Safety Day, this year is all about ensuring that we get the right diagnosis for patients in order that they have the right care and safe care. Other than safe, right care, I want that care to be delivered in the right place. And guess what? About 80% of my care has probably been delivered in the wrong place. And I think the same for a lot of people. We often get people brought into secondary care not because they should be there, but because the alternatives that should be there aren't. And so we need to do better, as we expect with the discussions with Aradazi and with the Minister, will turn us towards more community care-based, community-focused care. I want my care delivered by the right person. The quick way of saying this to anybody that knows is, if you've ever had a blood gas taken from you, the one person you do not want walking towards you is a Foundation 1-year student doctor or doctor in training. Blimey, it's going to hurt before you've even started, and that's just watching him undo the paper. You want the right person to be delivering your care. Now, don't take it personally, clinicians. Most of the time, the right person is a nurse or a nursing associate or a healthcare professional who is not a doctor. I want the doctors. I want them in the right place, doing the right job in the right way, but actually I want the right person delivering my care 100% of the time. So make sure we have the right team together. When we say MDT or multidisciplinary team, it means a wide range of people, not just clinicians. Do it right and do it once. I can't tell you the number of times the lab have said there wasn't enough blood in that tube and you've had to have the blood taken again. Or alternatively, the x-ray wasn't quite positioned right or wasn't quite set at the right and you had to go back for another load of x-rays. If we're going to be really good at what we do, then let's only put patients through things once and not have to keep doing it over and over again. One of the things I really want you to do is respect me. Now, be careful here. I don't care if you like me. I do care if you respect me and respect my views and respect the way in which I wish to deal with my health. And I think we need to ensure that we both have empathy of care but also respect for patients. And I will also admit, some of us are complete pains in the arse. Patients are not always the easiest people to deal with. But hey, guess what? They're going through some crap. And they need support, care, and respect in their decisions. I'm an individual. I always say this because as an individual, I've probably got the longest list of drug allergies I know. And one of which is streptokinase, which used to be given by ambulance crews if they thought you were having a heart attack, automatically. So if I didn't wear an emergency bracelet, they said, please don't do that to me. They would just follow a protocol and end up actually killing me rather than actually giving me the right medication or the right information. Patients are all individuals and we should treat them as individuals. And I agree that we need to cater around pathways and to bring all patients who need the right care in the right direction. But still, even within a pathway, we need to treat people as individuals. And finally, guess what, guys? It's my life, and therefore it's my choice. And what I mean by that is it might be my choice to ask you for a treatment escalation plan, even if you don't believe it's the right time to do it. It might be my choice not to have the 9th portacath fitted because I've not had too many IVs, even if you think it's going to be an absolute nightmare to get a line in me in an emergency. It might be my choice to actually stay at home longer than you might think is necessary. But it is my life, and therefore I have the right to make the decisions. And as Francis will come on to tell you, shared decision making and the ability of patients to make decisions with the right information is key to all of our care choices. Now, quick question just to see the observational people in the room. What's the deliberate mistake? What was that? There's only 7. You're absolutely right, there's only 7. But the reason there's 8 steps is this. Between each and every single one of those, there's a gap. And there's a gap deliberately. And the 8th thing is, please, please listen. At every stage, in between every stage. Key to getting it right for patients, for our communities, for our populations, both as ICSs and as we develop the long-term plan, is we need to listen. So if he was listening, I would very happily tell our new health minister, you failed at the first step. Because your first announcement was, I'm going to ask Aradazi to do a review of the NHS, but we won't be asking for public consultation at this stage. We're going to wait until we review the long-term plan before we ask the public whether or not the NHS is doing a good job. So, from my point of view, failed at first point because he isn't listening at the right time, which is at the very early stages. So the 8th step is always listen, and listen intently, and listen actively. I'm going to hand over to a wonderful colleague of mine. Her name is Frances, and she's going to talk you through some history.
Thank you, Jono. My name's Frances Tippett, and I've had the absolute privilege for the last 10 years to be working in the Southwest region, leading the collaborative that we built with multi-sectors to really see if we could implement personalised care. And I'm also the chair-elect of the Coalition for Personalised Care, which we're currently going through the process of registering as an independent charity. So if you're interested in hearing more about the Coalition, please do come and nab on me during the day. So, the first lesson that I think we can draw is that change is a constant. This is just some of the reorganisations that we've had during, my career. Obviously, there are some that go back even further than that since the NHS was formed in 1948. But what we can see is the speed of reorganisation just keeps getting faster and faster and faster. Reorganisation is the first way in which change is driven in this country. We also have plans, a new plan. But I think if you take some time and read through these, and they also appear in many of the other documents that you can see coming, including reviews, such as the Francis Review and others around safety, that key themes are a constant. High quality care runs through all of these as an aspiration that we must make a reality. Integration of health and social care. That's been around repeatedly since 1919. And I think we can see as well, if we actually start from our experience of working, there is much wider partners. Absolutely health, also police, justice. There's a whole range of organisations. And when you say health and social care, it's not just social care, it's the local government as a whole, plus the voluntary and community sector and independent sector. The more integrated support is, the more likely it is to be genuinely personalised. Patient safety, a theme running through everything. Using new technology. Investment in primary care, diagnosis, mental health, and taking the pressure off A&E. Key themes that have been running for a quarter of a century. Are we achieving them? So what's next? We know we've got a report coming out later this week. We know that we're having a refresh of the long-term plan, or whether it will be a new plan, but I suspect those themes are going to be in there. So the first question I'd ask is, are we reviewing how well we implemented the last plan when we create the next plan? Those of you who've been involved in planning rounds within organisations, how often is the first question that you ask, did we do what we said we were going to do last year? I wonder what a difference that would make if we did that. That might be one way of illustrating that we are a learning, evidence-based culture. Following through what Jono was saying, actually involving communities, patients, their carers, as an evidence-based culture, do we routinely capture experience of care measures? And do restructures help the implementation of reform or make it harder to scale up change? Certainly my experience of multiple restructures is that the unintended consequence is a lot of new development work, which is going really well, is too small a scale to feature on a whole organisation restructure and gets killed off. No one seeks to do that deliberately, but it is an unintended consequence. So how do we garner against that? So what if we deliberately built on what's come before? And I'd like to talk to you very quickly, and it's literally 2 minutes, about personalised care, where it's been a learning and building movement for decades now. And just a quick reminder for those of you who aren't aware of it, I'm sure you are. I know I've spoken to a few people here who are delivering personalised care brilliantly, is that people will get more control over their health and more personalised care when they need it. If you look at the timeline, I don't know if you can see that, but there's a range of things that you can say. You can look through and see there's some of the learning was taken for each of these to the next step in how this work was developed. Partly because co-design and co-production has been at the heart of it. There was also huge amounts of learning from previous programmes that got wired in until the comprehensive model of personalised care was developed in 2019. The operating model for it is in place. Huge amount of investment has been done. But my question now is that personalised care is business as usual. Is it? Really? Personal health budgets is the one measure that will continue to be counted from the previous personalised care dashboard. And under the NHS mandate, certain groups of people have a right to have a personal health budget. If we look at the model, we've got a population of 69 million-ish. 5% of the population are the people who, according to the national policy model, have complex needs and would benefit particularly from a personal health or an integrated budget. So, circa 3.5 million. As of the end of the financial year just gone, the reporting year, 189,000 almost people had a personal health budget. And not all of those people were in that group of the most complex needs. So that's less than 6% of the population. So I don't think we're good at measuring business as usual. I don't think we're good at implementing and scaling up change en masse. And that's the learning challenge that I would like to pose today about what would make it better, focusing on the behaviour change. Now, we can see that some places around this reform have gone further than others, and whichever kind of implementation you look at, there will be pockets that have gone further faster. How do we capture those? How do we share that learning more effectively? And what we certainly have learnt in the South West is that our communities of practice, sharing and learning networks, using early adopters, particularly people from the same discipline or team, to convince other colleagues of change, and making recognition of innovation through awards and storytelling of the difference that it's made to people, and then slipping some data in behind that, has had a multiplier effect. And it's very different to the traditional programme management of change. And it also requires, as a leader, and I have to put my hands up and confess here, that I am a recovering control freak. You know, I went into the kind of work I did because I loved organising things and I loved doing it myself. But actually, you cannot do something which is a scale of change, whole population, yourself. You just can't. And that actually the best way we can focus is how do we enable and empower people to become passionate about it, to own the change themselves and to drive it and be creative about how they implement it. So the takeaway for today that I would like you to think about, or invite you to think about, as we plan for tomorrow, are we taking forward with us the things that have worked so far? And crucially, the people who have made change happen. So many times I've seen people who have led individual projects that have worked incredibly well, and there's a collected diligently and evidence-based to show that it worked and it saved money and people liked it and the outcomes were better. Because it was small scale, is lost. And those people are crushed. They're your innovators. They're the people who can make things happen. And crucially, recognising and taking those people with you is so essential. Fully implementing a change before moving on to the next initiative. How do we know that it's done? Do we routinely do as I did earlier? Look at a policy model, extrapolate. What does that mean in our ICB? How many people would that impact? How many people are we doing it now? What's the gap? Have we done it or not? What's the percentage of done are we? Are we a learning and evidence-based culture? Asking that, and how do we demonstrate that? How do we show that? Including things like, are we routinely capturing experience of care measures for people, carers, and the staff that are delivering the work? Are we empowering people to make change happen? And what could we do that's different? We use restructuring and planning as our default go-to ways of driving change. And I'm not suggesting we abandon doing that. Getting the right structures in place and having a good, coherent plan that everyone can follow makes absolute sense. But also, so does following through on the behaviour change and understanding how we create habits and recognising that we need to shift people's mindsets and take them with us and empower them to own the change themselves if we genuinely want to scale something up. Thank you. Jono.